Fairfax area. I've been on staff at all the hospitals here for over 20 years at Fairfax, Rreston, Fair Oaks Hospital, at Prince William Hospital, Manassas, and Potomac Hospital in Woodbridge. And originally, I was on staff at Georgetown University Hospital, where I trained in urology. And then as the urology developed out in the local hospitals and the equipment got better, there was no need to go into DC to use the Georgetown equipment. But I've been in practice here for that much time, and number of colleagues. Even though I'm a solo practice, I'm in practice with the Advanced Urology Associates Urology, minimally invasive and therapeutic treatments for prostate, kidney, bladder. Today I'm going to talk to you about prostate enlargement, BPH, and patient information, possible treatment options, and we're going to take any questions at the end, or you can feel free to raise your hand or interrupt me if you have any questions during this presentation. And we should have you all out of here on time. If anyone's coming from farther away, sometimes I have patients who do come from out of state, especially if they're parents of my younger patients. They'll come into town from Florida and have a prostate procedure just because they've heard about this and no one locally is doing it. But being just 4 minutes from Dulles Airport and 30 minutes from Reagan National, and a lot of places to stay here conveniently, it worked out well for the patient. When I first started doing these minimally invasive therapies, I've had a patient come from Rhode Island, in fact, because the one they were doing it, his golf partner happened to have lived here and had the prostate therapy, which was a good outcome. But now they're more spread out throughout the country. All these treatments are more readily available. This is the anatomy of the prostate gland. It's the location basically between the urethra and the bladder. It's kind of halfway point here, works as a control valve, doesn't do too much for you except possibly cause problems, doesn't produce any useful hormones. That's the prostate. It's here. And can get enlarged and obstruct. So common symptoms of prostate disorders: increased frequency of urination, especially at night, sudden urgent need to urinate, painful or difficult urination, slow flow of urine, difficulty in stopping, terminal dribbling or leaking, or incomplete emptying of the bladder. Way to keep the prostate healthy, as far as we know, there are many old wives' tales of herbal treatments. Fundamentally, is what keeps the heart healthy, is what keeps the prostate healthy. And stress, other factors that can affect prostate symptoms: stress, obesity, cigarette smoking, inactivity, too much sitting on the couch instead of being active. So therapies would be preventative measure: reduce stress, eat healthy, keep active, quit smoking, and no tobacco use. In order to assess the prostate health, regular exams should be done at the age of 50 or sooner if their patients are having symptoms. I had a patient who was 42 years old, in fact, came into the emergency room here at Rreston Hospital, had 2 quarts in his bladder that at that time couldn't pass in the urine well. It's been going on for months, and it was benign. It was not prostate cancer. He had a family history of it. Father, grandfather had it, and he presumed his symptoms were normal. Eventually, after opening up the prostate blockage, he was able to empty his bladder, but not completely. The bladder never did recover entirely bladder function, so you can have some permanent damage of the bladder overstretching it for too long. No urology numbers, that means these symptom scores. There's the American Urological Association symptom score. And that's nothing more than a handout sheet we give patients on a clipboard, and you assess on 7 questions as to how your symptoms have been over the past couple of weeks. And the total worst score could be 35, and the best could be 1 or 0. There's a prostate-specific antigen. That's a prostate screening. Prostate cancer screening test is one you've read about or heard about a lot. That the media is saying it may not be valuable, but it's still our best test. There are false positives, false negatives, Medicare will only pay for that once a year, unless it is rising. If they have a rising or abnormal PSA, they'll pay for it to be repeated more frequently, or they've had prostate cancer. Testosterone levels, central to a man's sex drive, energy level, muscle strength, and bone density. You hear a lot about this on advertising on television, low testosterone and testosterone supplements. You'll also see a lot from lawyers who want to sue doctors now who are prescribing testosterone who didn't need it, or they develop other heart symptoms. So scaring doctors away from prescribing it. Listen, I personally don't prescribe unless I got a proven low testosterone blood level on a lab test. Because it's proven that if it's already normal, more won't help you. Common disorders of the prostate gland, we see prostatitis, which is swelling or infection of the prostate gland. Low testosterone, decreased functional activity from the testicles that produce testosterone. Erectile dysfunction, is inability to maintain erection sufficient for satisfying sexual activity. BPH is benign prostate hypertrophy, and that's simply enlargement of the natural prostate gland. Not to be confused with prostate cancer, which is a malignant cancerous disease that forms in the prostate tissue. It is the most common condition, actually, in men over the age of 50. That's mostly symptomatic. Very few people die of this prostate enlargement, unless they have an infection that spreads into their bloodstream, or a long-term destruction can obstruct the kidneys and cause renal failure. 50% of men in their 50s experience prostate enlargement symptoms. And by the time they're in their 70s and 80s, in men, 90% of men are having some prostate symptoms. And what is BPH on this slide? It's where the prostate cells begin to increase in number. So these natural cells have already been predisposed genetically to enlarge or not enlarge based on family tendency. Will then begin to increase and grow in the presence of testosterone, usually after the age of 40. Not cancerous, not life-threatening. The symptoms can be bothersome and impact the quality of life. It can progress to more serious conditions, and very common in men over the age of 50. This would be a normal prostate in this model here. A normal prostate should be open enough that the bladder can empty, and it works. It is one of the control valves. Essentially, it's the internal sphincter that closes in the prostate. It will tighten based on the muscle fibers that retain the urine. So patients who do have a radical prostate surgery will home, I got to be continent. This muscle, this additional valve in men and women have this external striated sphincter, and they're running on one valve essentially if you remove the whole prostate gland. But it does strengthen in time, and you can have complete continence without having a prostate gland. Now this is an enlarged prostate gland, and instead of being open in this channel for the bladder urine to come out through the urethra, it begins to compress as if they were two pillows. And you think of the donut idea where the prostate is like a round donut with a hole in the center. As the prostate starts to enlarge, that hole becomes smaller. Restriction of flow occurs, eventually causing a puddling of urine in the bladder, incomplete emptying. These are the openings to the kidneys here. It's anatomically where they are in the ureters. Back pressure can force that urine back up these tubes, called retrograde reflux, and cause kidney damage due to high pressure. Signs and symptoms. Waking up at night to urinate, one of the early symptoms. Going more frequently, and that can be due to reduced bladder capacity or overflow. The bladder is overfull, it's not empty. Sudden uncontrollable urges. The bladder reacts to the restriction of the prostate, becomes hyper-irritable, hyperactive. It wants to contract. It doesn't give you the warning that it had before. You've got to get to the bathroom quickly. So it becomes hyper-irritable, hyperactive, hypertrophic, hypertonic, means swollen, hyper-irritable, and stronger. Weak urine flow, dribbling after urination, meaning that the bladder becomes so hyperactive it can't learn to relax when it's actually trying to stop going. It keeps wanting empty even though there's not much left in there. That's the post-void dribbling. And the feeling that bladder is not completely empty may be real, not just a feeling, but a simple ultrasound of the kidneys and bladder can determine that there is a post-void residual or retention of urine, and you cannot feel, may not know. The bladder does not have proprioceptive fibers in the muscle to tell it when it's quarter full, half full, three quarters. It just knows when it feels like it's empty or you think it's full or close to full. And pain during urination is another possible symptom. The medical consequences, if the prostate hypertrophy or enlargement is not treated, could be this urinary retention, where they cannot go at all. We see this around Christmas time, holidays, when men are at parties, are drinking coffee, caffeine, diuretic, and drinking alcohol. Both of those double whammies cause a lot of extra fluid excretion by the kidneys, and the alcohol can suppress the sensory level, not realizing it's getting overfull. It becomes a point of no return. They end up in an emergency room with a catheter because the bladder is overdistended. Urinary tract infections occur whenever the bladder doesn't empty completely because the urologic principle, urinary stasis will lead to recurrent infections. So if there's more than 10 ounces in the bladder, it's going to start causing infections or bladder stones. The bladder stays healthy by emptying completely and 100% each time. The bacteria that get in through the urethra will be washed out before they develop into an infection. Blood in the urine can be seen. That's the most common cause of blood in the urine in men is prostate enlargement. Not bladder cancer, not prostate cancer, kidney cancer. It's just prostate enlargement, causing the blood vessels to become enlarged and bleeding. Incontinence, leakage of urine, requiring the use of pads. Another potential consequence of prostate enlargement, and as I mentioned earlier, if you get back up from the bladder to the kidneys, you can start losing kidney function and can be permanent. It may not be reversible. So the physical examination, if I see a patient in the office with prostate problem, referred to me by an internist or a family practice doctor, often in the community. There's a physical examination of the prostate gland. Symptom scores, I mentioned earlier, it's a sheet of paper you fill out the baseline of how bad are the symptoms. We use that especially after some kind of treatment to see is it better or worse. If you later on do that symptom score, and interestingly, patients will forget what their symptoms were like a year ago. So it's good to reference that sheet back to them again, say this is what you showed us last year, this is what you're doing right now. Urinalysis, rule out infection, blood in urine. This PSA blood test, prostate-specific antigen, should be done in all patients over the age of 50 to check for prostate cancer, or if they have prostate symptoms and are younger. I've had a patient who was 38 years old with prostate cancer, and ended up having a radical prostatectomy cured. And he's not the record holder. One of my colleagues, Dave McLeod from Walter Reed, since they examined all patients, all new recruits, completed examination, found a prostate nodule in somebody 19 years old with prostate cancer. So you can pick him up with a normal PSA. I've found patients in the past 2 weeks, normal PSA but prostate nodule. So physical examination, there's no substitute for it. And the combination of the PSA blood test and physical examination is really the best way to screen for any prostate cancer. Flow rate, something we do in the office. Emptying the bladder, voiding into a basin, a fancy toilet connected to the computer, and it gives a readout of peak flow rate, average flow rate, minutes per second, and sonogram can tell us how much is post-void residual. So with a totally non-invasive examination, there's no need to put a catheter in the bladder to measure the residual. We just do an ultrasound. It tells us quickly, 3D ultrasound. These are the AUA guidelines on treatment for prostate enlargement or evaluation. So patient assessment and testing, we just mentioned those things that will be done. Next, we do the symptom score, and the symptom score goes to 0 to 35. If it's less than 7 total, you consider that not bothersome to the patient, and may not really require any symptoms. Treatment, just observation. So that is watchful waiting. Do nothing. So see the patient back in 6 months or a year, see how it's progressing, maybe do an ultrasound if we see residual urine. Monitor that. Monitor moderate and severe symptoms, anything over 9, or if the symptoms are borderline and it's bothering the patient. Just don't like getting up that many times a night. That's my only symptom, but I can't stand it any longer. All right, just can't go shopping, got to go for a men's room at the mall. So then at that point we discuss the treatment options. Those three are medical therapy, variety of medication pills that can help the prostate gland. In-office therapy, these are minimally invasive therapies that can be done in the office, varying from balloon dilation, which is not done very much anymore, but microwave therapy or radio frequency. And then there's surgery, transurethral resection, or you do full anesthetic. You do it at the hospital. We do it with a laser, variety of lasers, indigo laser. There's a blue, indigo and green light, PVP laser. There's a holmium laser. There's a lot of ways to laser the prostate gland, but those are more complicated, requiring general anesthetic and clearly hospital visits and catheter. So here they are again: the watchful waiting, medication, in-office therapy, or surgery. Watchful waiting, those are the symptoms, the symptom score of 7 or less, not bothersome to the patient. I recommend leaving it alone because there's nothing you can't make worse with surgery, sure. Ongoing assessments once or twice a year. So you monitor the symptom progression, easy, ask the patient the simple questions, do the symptom score sheet to check for disease progression, getting bigger or worse, check for infection with the urine test, and sonogram can tell us if there's kidney or bladder stones as a result of the obstruction. There's a lot of herbal supplements, and you see them advertised, football players on TV, Joe Theismann advocating one that he takes and help him. Of all the supplements, though, that you see over the counter or be mailed to your home with a guarantee of refund, no patient so far has told me they've ever got a refund back from the pills they bought. But they are not recommended by the American Neurological Association. There is no evidence of efficacy on these herbal supplements. Most recent one that was tested in the Journal of the American Medical Association, a real good, well-controlled study regarding salt palmetto, which is in most of the prostate supplement bottles, had no effect whatsoever. Although I have not seen any harm from that to any patients either. And I've had a few patients say it did help them, in fact. Could be psychological, but either way it is helping them. I don't recommend it. They can increase your risk of bleeding. Many of these medicines, like this Pygeum africanum, or stinging nettle extract, they can actually prolong. They have an aspirin type effect that can cause prolonged bleeding for some patients and affect other medications, especially blood thinners. So these are the most popular ones: salt palmetto, beta-sitosterol extract, Pygeum africanum is the full name of that, ryegrass extract, stinging nettle extract. Of the real medications that are FDA approved for prostate enlargement and blockage, there are two major categories. Alpha blockers, you may see commercials for these things like Flomax. There's a Cardura, they've been around for a while, they're effective. There's a newer one, Rapaflo. The newer they are, less likely your insurance will pay for them. You have a higher copay or they'll deny it. There are 5 ARIs, are the androgen receptor antagonists. These are Avodart and Proscar. This one is in a generic form now called finasteride. Avodart is still prescription strength and is a little more powerful than the Proscar. J-Lin is a newer combination now of these two medicines, Flomax and the ARI together in one pill. So some patients like that. Many insurance companies do cover the combination pill as well. The drugs are still the most common treatment option. We do treat patients, usually give that option first, see how they react. If it works for them, they can afford it, they don't have the side effects, they can keep taking the medication. My experience, the Flomax, this group of blockers, eventually starts having less of an effect, requiring a higher and higher dosage. Their common side effect would be lowering the blood pressure. So you can only go so high before the blood pressure starts dropping out. And then you got to look for some other form of treatment. Flomax, usual dose is 1 a day, for example, or Cardura, but we double those up safely with patients, double dose, but beyond that, You've got to go to some other treatment. 94% of patients are treated with medications, but this is a very important point here that only 48% of patients 48% do not show any symptom improvement, so almost half. Even though almost everybody's treated with it, only half really respond to it. But it is recommended to try that.
Excuse me, why do doctors consider prescribing that if 48% don't get any benefit? That's half.
Yeah, it is. The reason is that it's recommended by the American Urological Association, and many of the insurance companies won't approve a procedure until you try the medication first. They believe that if it's just one medication and it's generic, it'll save them money. And most of the insurance companies are interested in not your health or welfare. They're interested in profit margin and the bonus for the CEO. So if they can do less procedures that would cause them additional expense now, they'd rather not do that. Treat somebody with a medication, certainly, that you can take for a year. Maybe they'll change their insurance company to another one, possibly. They'll no longer have to deal with that expense. And since any procedure could have a complication, if there's any invasive whatsoever, you've avoided a complication with any possible treatment if you're trying the medications. So that's the reason. Start with the medications just because it's recommended in the patient. And some patients don't want to. Some patients say, I'm going to bypass that. It's not a must. The patient says, I don't want to try, I don't want to take, I'm already taking 10 pills a day. I don't want to take 2 more. Or I'm paying one patient told me he's taking paying $2,000 a month for his variety of medications for arthritis, blood pressure, thyroid. He doesn't want to take any more. So I'd rather do a definitive procedure rather than taking more pills, and I don't want more co-pays. So they don't have to do that, but we do give that patient an option, treating the medications first. So possible side effects. The first category, this alpha blocker, this includes the Flomax, Rapid Flow, and Avigard. Flomax, Cardura, and Rapid Flow. Those are the 3 common alpha blockers. They relax the bladder neck and basically allow the bladder neck to funnel better, urine to flow out easier. It doesn't reduce the prostate at all in any way. It just allows it to open easier. Side effects could be reduced blood pressure. They originally were designed as blood pressure medications, alpha blockers. And we did use them, and they were purely blood pressure medicines for the side effect of improving the urine flow. But then these advanced ones came out, which reduced the blood pressure less, improve the urine flow more. Headache, it does dilate the blood vessels in the scalp, so you can get vascular headaches. You get nasal, nasal congestion dilates the nasal vessels, pounding heartbeat, nausea, weakness, weight gain, floppy iris syndrome. So if you're ever going to consider, for example, a cataract operation, this is the one that can cause complications with the cataract operation. This is the Flomax medication particularly can cause a complication. So we have to stop that. And always let patients know that and talk to their ophthalmologist before they do that surgery if they're on this medicine. These are the medicines, these ARIs, these 5-alpha reductase inhibitors. This would include again the Proscar and any medicine that blocks the hormones that allow the prostate cells to grow, including the combination medicine. But they have a side effect of erectile dysfunction, probably about 4.5% of patients, lowered sexual drive, libido, decrease in semen released during ejaculation, that's called retrograde ejaculation, decreased PSA levels. So anybody who's on these medicines, always remember, once they've been on it for several months, 3 months or so, I always get a new PSA blood level for prostate cancer screening because it's roughly reduced by about 50% by the medication. So you have a new baseline. So the drug therapy advantages, they're simple to use, they're fast symptom relief. They actually can work within 24 hours. So patients say, why do we try medications? This is one good indication. These get them over the hump and get their bladder flowing again. This can work within 24 hours like Flomax. Doesn't require surgery, anesthesia, or hospital stay, or associated side effects. There's a low rate of side effects overall compared to other medications for other diseases. Covered by Medicare and other private insurance companies, and they like it. Now the in-office therapies, what can we do in the office for prostate enlargement? These are two common options. Transurethral microwave thermal therapy, which is abbreviated TUMT. And it's also called more recently cool thermal therapy, because even though this catheter emits microwave energy a short distance from the catheter to shrink this blockage tissue in order to not damage the lining of the prostate gland, there's actually a thin jacket around this catheter right here that has a constant pump that cools cold water through it, so not to harm the urethra, as opposed to laser procedures, TURP, where you're cutting the lining right out to get to that tissue. But how are you going to get that tissue out without cutting lining? You need a therapy that can protect that lining. And the reason you want it there is because it prevents bleeding, hemorrhage, scarring, as long as that natural lining is in there. So that's one great advantage of the cool thermal therapy. The second therapy, and that's also very good for very large prostate glands. People can't urinate at all. This is the transurethral needle ablation, formerly called TUNA, T-U-N-A. Now the current name, since Medtronic bought up their technology, they changed the name to Prostiva. Sounds more appealing, more like a prostate therapy. And it's radio frequency ablation, not microwave. And this is precisely targeted, low-level radio frequency energy for small glands or atypical prostates. In other words, atypical means that they may not be a perfectly round apple shape or orange shape. If it has a middle lobe bulging up, this therapy cannot be done. It has to be perfectly symmetrical. You want to do this where you directly visualize the blockage tissue through a scope during the procedure and treat the areas where the blockage is visibly occurring. It also protects the lining because the radio frequency energy is delivered by these tiny, almost microscopic antennae that project into the lining, small as a needle, and don't cause damage to the lining. In that way, energy is emitted in these oval-shaped treatment zones right under the surface, also not affecting the control valve, stays well away from this control valve. You don't see incontinence problems, doesn't harm the nerve supply for erectile function, which actually runs outside the prostate, outside this capsule. This treatment doesn't damage that. So during the treatment, the in-office procedures, the pre-procedure preparation is 15 to 20 minutes, where I give patients oral sedation. They can try a liquid cocktail of anesthetic and sedation in combination with a topical local anesthetic. So that takes a while for it to work, about 15 to 20 minutes. So there's medications given for relaxation and comfort. The comfort levels are generally tolerable and reported on a scale of 10 to be in a range of 2 or 3 only. I don't have patients getting up and leaving and saying, this is too much for me. New prostate blocks being performed may eliminate discomfort. I find it may be particularly useful when my patients already have had prostatitis recurrently, their prostate's already irritated and sensitive. They may need a little booster of local anesthetic, which I can place with a ultrasound guidance into the prostate tissue before we even start.
Doctor,
Yes.
when it says comfort levels generally tolerable, does that mean the medication is causing the discomfort or the actual process is causing discomfort?
The actual process is
Okay.
causing discomfort. And that's where the 2 or 3 ends together, because it generates heat. It's a thermal ablation, and so it's actually heating that tissue up in those spots hot enough to destroy that overgrown glandular tissue. And it does it in a slow fashion, just at the right temperature. We do it gradually. It defunctionalizes those overgrown cells, They are gradually eliminated by the bloodstream, circulating through the prostate gland, eliminating those destroyed overgrown cells. The prostate then begins to open up. The donut shrinks essentially. The channel opens up in the center. So it isn't an immediate improvement because we're not truly cutting the prostate out tissue physically. It's naturally eliminated, eventually through the biliary liver, which eliminates destroyed cells or worn out cells and replenished cells in the body through the bile, then the GI tract. That's how it eventually disappears. So that's why the maximal effect may not be for a year. Recovery time is generally 15 to 20 minutes. There's post-operative, will include post-operative treatment instructions, so the staff, the nurses will go over the instruction sheets that are usually prepared for the patient, but read it to them anyway, with the family members to recall all details. So after the treatment, the patients go home shortly after treatment. Someone has to drive them home because they've had some kind of anesthetic. They don't allow them to drive home themselves. Urinary catheter or temporary stem may be required for a few days. Not very common in my patients. We use a anti-inflammatory regimen preventing the initial swelling of the prostate gland. So 9 out of 10 patients do not, in my practice, need any kind of catheter leaving the office. And they return to normal activities within 24 to 48 hours. So technically, patients can go back to work the next day. I tell patients if they have sick leave, they have time off, take an extra day and stay home and rest and treat a little operation like a big operation. Generally, they'll do better. They're pampering themselves a little bit. Symptom improvement generally seen in 8 to 10 weeks. So it's not tomorrow or the next day. It takes weeks for you to notice some improving. Lasting and significant relief from the symptoms. That's proven compared to long-term studies that the patients have had these treatments. But all treatments for the prostate gland, must remember, are not permanent. The prostate will regenerate in time. That natural prostate tissue will want to regrow back and will eventually cause symptoms.
How long does that take to
On the average, about 5 years.
Oh.
But the procedure is repeatable. You can do it again. I've had one patient go 9 years. I've seen him follow up 9 years since I started doing the procedures, and he's still doing well. There is a variability in the initial size and how bad was the obstruction. You only remove a finite amount of tissue with therapy. With this therapy, it grows back, and it was already super large. You can imagine it may want to restrict sooner. It may not have as long of an effect as somebody who started out with a medium size but obstructive prostate gland. So the advantages of in-office therapy, it's very effective at relieving the symptoms, proven long-acting results, it eliminates the need for chronic medication, lower the risk. It is a lower risk than invasive surgical procedures. We're talking about transurethral resection or the laser procedures requiring general anesthesia and catheter drainage for a prolonged period. It's completed in the urologist's office, less than an hour, no hospitalization, there's no general anesthesia or long recovery time. There's a quick return to normal activities, there's a low rate of side effects. It's covered by Medicare and many private insurance companies. Now there are side effects, everything has side effects, nothing is 100% of any surgery. And so the microwave therapy, you can see blood in the urine afterwards for the first couple of days. You could have some a burning sensation in the urine. We do give patients, all patients, medication to prevent burning sensation in urine after the procedure. Blood in the urine can be seen for, in other words, this doesn't mean a lot of blood in the urine. There will be patients who already had severe obstruction, prostate, varicose veins that would bleed easily upon contact. They're more likely to see active bleeding in the urine. You can see clots in the urine. It could obstruct the urine flow potentially. I say pretty rare, but these are possible. You could have painful or difficult urination. Tell patients that within the first 2 weeks, your symptoms could be a little worse, in fact, as the prostate may swell a little bit in reaction to the therapy. It's called reactive inflammatory edema. Rectal irritation, that's only with this procedure because there is a transrectal ultrasound monitoring probe that feeds back to the computer. If you already had hemorrhoid problem or some other Crohn's or something, a colon, they would be more susceptible to that. Temporary inability to control urination, could be hyper-irritable. There's inability to discharge semen and orgasm, called retrograde ejaculation. Brief inability to maintain an erection. That would be, again, just not a permanent side effect. The transurethral needle ablation, the Prostate, this side effects of possible blockage, like the other one could, if you had initial swelling after the procedure. You could see some blood in the urine in the first day or two, or bleeding, especially say if you had varicose veins. You may have pain or discomfort. Although I give all patients pain pills after the procedure, I would say maybe 1 in 20 actually takes any of the pain pills after the procedure. Tylenol would usually be plenty, but they have it available. And this is because they don't have any long-lasting burning sensation, aren't burning the lining out like the laser procedures, which will truly cause pain, and we have pain for a good 2 weeks with lasers. But these in-office procedures do not disrupt the urethral lining or burn it. You're going to have urgency to urinate, especially early on, and that will go away. There's increased urinary frequency. You may go more frequent than you did before temporarily as the prostate reacts to the treatment itself. And you can develop a urinary tract infection if, even though it's a sterile procedure, sterile equipment, sterile prep, antibiotic preparation, it's always possible that the bacteria from the skin could get into the prostate and bladder and cause an infection. Surgery options are this transurethral resection. This used to be considered the gold standard. This has been around since 1920. And we actually, through a scope, physically cut out the tissue inside the prostate, cut the lining out first, and cut the tissue out, and wash the pieces out with the irrigation, and cauterize all the bleeding that you can. So that's surgical removal of part of an enlarged prostate gland. Button Turk relates to this laser vaporization. It's a heat effect, electrocurrent that causes a heat effect and vaporizes the tissue by burning the lining first and vaporizing it. Then the variety of lasers that are available. You may hear this term frequently, the green light laser, or holmium laser, abbreviated as HOLAP, where the laser is concentrated light that is used to generate intense heat to shrink or remove excessive tissue.
Going back to that, sir, which
Yes.
of those do you recommend or do you perform? I mean, there were.
If I had a patient who I thought was too much and too much obstruction to do either of the other procedures, and had a significant bleeding problem, and I thought he needed the hospital operation, I would still go back to this old gold standard here myself. This transurethral resection. They can visibly shave the tissue out, and they have an immediate improvement in flow rate. They do require a catheter for several days, but it does have the most immediate effect and least post-operative discomfort compared to the laser procedure. So patients will have pain for 2 weeks on the average. And the reason I stopped doing these laser procedures, I saw a number of strictures where scar tissue can develop from a laser, as instead of healing, a new lining forming inside that donut is replaced by scar tissue. You don't get a natural lining back again exactly. And like scar tissue anywhere in the body after injury, scar, surgery, or accident can become thick, stiff tissue. It becomes inelastic. Those patients can have a permanent obstructive and irritative symptoms. And I've seen some that were done elsewhere, came to me for a second opinion. I looked inside, I said, looks open to me. I don't know why you have the symptoms, but it's more like a concrete tunnel through there, lost its elasticity. I said, I really can't fix it. Nothing more I can do, so maybe make it worse. So I abandoned these laser procedures myself. Although a lot of urologists still have had some good success with it. I don't want to take that risk myself. I'd rather go back to that old gold standard, do this, or an office procedure, in my in my surgery advantages of these surgical procedures: immediate relief, and the patient who has a hugely distended bladder, can't urinate at all, comes in with a catheter he's had for weeks. Might be a good option for some patients. And there's a long history of the success with this TURP. As I said, this dates back to the 1920s. The scopes are better, resectoscopes, the loops, the current, the cautery is all better now than it was even 20 years ago. But it's a proven modality. Can eliminate the need for chronic medication. So you can get off the medication, but so can you with the office procedures. Eventually, after the year, get off of those two categories of medications. Covered by Medicare and many private insurance companies, so there's advantages. Risk side effects of the TURP, the one I mentioned, which is the old gold standard. It does require general anesthesia or spinal or epidural. You can't have an intracapsular perforation. You can cut too deeply with that resectoscope and cut right out through the wall of the prostate gland. That happens sometimes. You can have a TUR syndrome. This is where, because you need a high volume of fluid when you're cutting with the scope and rapidly bleeding, you've got to keep irrigating and you keep cauterizing. You cut through some veins in the process, big veins. You get an infusion of this irrigation fluid, and so you get hyponatremic. They dilute their electrolytes, and they need to go. They can have cardiac complications. Transfusion, if you lose enough blood, they've been on blood thinners and you're resecting that tissue, and then you've got to get it out, they may need a transfusion to lose so much blood. Postoperative pain or discomfort, it's going to be there. If you're resecting it, you've got a catheter, and you've got an area you're burning to stop the bleeding. Infection, risk, but you're going to leave a little catheter for a longer period of time. Retrograde ejaculation, more common with this because they're cutting deeply that tissue out of the bladder and neck. Erection functions, erection problems, this is a real thing, and it's about 5% of patients will have after this transurethral resection. You can have painful urination, understandable. Laser, temporary difficulty urinating, so these patients will require a catheter for about a week. Urinary tract infection, possible with any treatment. Narrowing of the urethra. This is what I was talking about, the scarring that can occur. The scarring you may not be able to fix. Retrograde ejaculation, erectile dysfunction. Sometimes it's hard to control that depth of the laser burn too. But there's occasions of incontinence where they burn into the lining of a control sphincter. It's possible. So, winning solution. Urinary symptoms are a normal part of aging, expected to occur. It's not a real something you can prevent or directly caused by diet or activity. Generally hereditary. There are treatment options that can help restore the quality of life. If the patient is dissatisfied with the current therapy, please talk to your doctor about what other therapies may be suitable for you. So the common questions related to prostate therapies: how comfortable are you during the procedure? And I went over that already with the in-hospital ones. There'll be general anesthesia. You feel nothing during the procedure. In office, we have a combination of topical, local anesthetic, gel, and oral liquefied sedation. So generally, they're pretty comfortable. The results long-lasting. The in-office procedures, about 5 years. The transurethral resection, where you're truly cutting it out in there, you may get as much as 10 years. If it's a real deep resection. So it may be longer lasting, but the risks are higher with transurethral resection. Are they covered by insurance? Pretty much now, all insurance companies cover these prostate procedures. At one time, Medicare was requiring a second opinion for everybody who was doing this, a call-in approval. When that was stopped by Medicare because they realized that all the patients that were getting it pretty much needed it. They wouldn't want to volunteer to do the procedure unless they had the symptoms. So they didn't really get much denials or changes, so Medicare stopped doing these pre-approvals. The men weren't just coming in for the fun of it to get the procedures done. Then, if there are any patients who are family members who need, or might need this, there is a card that can be filled out for staff to contact the patient for scheduling. There's another one that can be filled out for just more information to get out to them. So thank you for coming. Anybody have any questions now about these therapies? Yes.
There's a time limit on both the more advanced surgeries and also on the prostate, because if I understand right, the prostate, after it's all over, the prostate will then continue to grow back and will cause the same conditions.
Yes, that's correct.
The medical treatment, which I'm using right now, essentially that shrinks the prostate, right?
One of them does, right?
The Proscar.
Right, the Proscar and Avodart, they shrink the
They
prostate
shrink,
gland.
and they maintain that, whereas Cardura may lose its effect. The other ones maintain the shrinkage, right?
Exactly.
So is a combination of Prostate and then follow up with continuing Proscar eliminate even the 5-year expiry date on the RF procedure?
That's a reasonable question, and I found that with my patients. The question was, can you, if you are already on medication, like Proscar, which shrinks the prostate and maintains in a shrunken condition, will it give you more time? And in fact, it does. I offer that to all my patients. If you're not having side effects from it, and it's affordable to you, after the minimally invasive therapy, continue taking the Proscar or Avodart, because it more likely will delay the need to ever have that done again. It will reduce the tendency of the prostate to grow back, delay that. Whereas the alpha blockers, the Cardura, the Flomax, the Rapaflow, they generally, they will be stopped as the prostate opens up for this treatment. There's no longer need to continue those. But if you did, they would gradually lose their effect. The body builds up a tolerance, essentially, to the medicine. You need a higher and higher dosage so it doesn't work anymore, in my experience. So it's not a good, real long-term treatment. The alpha blockers, the Rapaflow and Flomax. But Avodart and Proscar are a good long-term treatment. They're indicated for long-term treatment for prostate enlargement. So I say I found it to be preventative for recurrence. Yes. Any other question?
Yeah, I take Hitrin. Is that as effective as the other alpha blockers you mentioned?
It is. I mentioned earlier that some of the medicines we originally used off-label, and Hitrin is one of them. Cardura was another one that we used when it was discovered that the side effect would improve the urine flow. It actually not only lower the blood pressure, so it worked good for hypertension, but it also improved the urine flow. So we would prescribe that in patients who didn't have high blood pressure, and there were no other advanced medications, so it worked well, and they can be just as effective as the current ones. I still have a large number of patients who are on the original medications, Hitrin and Cardura, and I keep prescribing, refilling it for them because it helps their blood pressure. They have minimal need, and even some patients who've had the minimally invasive therapy, they tell them stay on it anyway because your primary doctor will want you to be on a blood pressure medicine as well. If they do stop it, they should probably get their other blood pressure medicines adjusted. If they no longer want it for the prostate or have side effects, still go adjust their high blood pressure medicines by their primary doctor or cardiologist. So the old ones do work, and if they don't have side effects and they're covered by insurance, low copay, I see no reason not to continue them.
How often do you suggest a man have a PSA exam?
I would say at least once a year after the age of 50. I offer patients who are even in their 40s or even 30s, if they have early onset of prostate blockage symptoms, I get at least a baseline. I say if it's normal and they're under 50, I wouldn't repeat it again until they are 50, and then start checking again. If it's high, then do more evaluation. But I would recommend doing it at least once a year.
I haven't had one in a couple of years, but my doctor has just a urine test said I've got a slight bit of blood, so I need to have another one, so I'll see. That's why I was interested in your presentation.
Yes. Now, blood in the urine is a whole different animal. Could be due to the prostate enlargement, and very well might be, but you still have to rule out kidney cancer, ureter cancer, bladder cancer, and with tests such as a dye contrast study, which would be an intravenous pyelogram or CT urogram to look at the kidneys and ureters, and there's no substitute for cystoscopy, looking into the bladder with a fiber optic scope to rule out superficial bladder cancer. That should be done, and it will be irrespective of the PSA blood test. Any other questions?
You listed a number of side effects. Do you actually tell patients, when you look at them, for example, of all these side effects, how many do you think I might get? You give them, because you basically know their condition. You can give an evaluation of what
That's a
they
good
might
question. I do tell all patients all the side effects, but I do then tell them a disclaimer, I really don't see this. I haven't seen this symptom, I'm in patients in years. But since it is a possibility, you need to know that it's there. For example, blood in the urine. I've had a patient who's had a problem with blood clot retention from the minimally invasive therapies in probably 6 years. Very rare. Maybe once in 9 years I've seen it. So they're usually a patient who's already on blood thinners, didn't stop it, or could only stop their Coumadin or Plavix for a certain number of days because of their heart condition. They're more prone to bleeding. So we handle them a little more cautiously, so they might more likely see blood in urine. With patients who are not on blood thinners, bleeding is not a big concern. I tell them it's not been a problem for my patients. Infection, very unlikely, because we give everybody preventative antibiotics, and we make sure that the urine culture is sterile before we do the procedure by doing a urine culture. So you don't start a procedure, and all the equipment is sterile, and had a history of infections. Infection risk is truly low. I tell them it's probably not going to happen. The erectile dysfunction problem, I tell patients that even though it's listed on there, it really shouldn't happen at anybody because the therapy is just under the lining of the prostate, not outside the capsule. It doesn't reach out that far where the nerves are. So, but it could be psychological. They may have stress-related erectile dysfunction. They had something done to the prostate, they're worried about it, they can't relax. They have a psychological impact, then they really have it. But that's where that percentage comes from, this 2%. Not because physiologically they really believe that anything caused it, but it can happen. Yes.
Statistically, on the Prostate, is there an overall success rate?
Overall success rate, in my experience, is well over 90%. Yes. Patients are generally very satisfied. And rarely hear anybody say, I'm sorry, I wish I'd never done this. Or most commonly I would hear the comment that if I knew it was going to be this easy, I would have done it years ago. Or if it grew back, I'd come back and do it again. I could have been, I wouldn't be worried about it. So that's the general impression I get. Most common comments. So we don't like to paint too rosy of a picture. Maybe somebody will have a side effect. And if I'm a professor at Georgetown, can't really tell anybody it's going to be 100%, because it might not be. Another professor in surgery said there's nothing you can't make worse with surgery. So we always give that medication option first and make sure the patient's really comfortable with it. If symptoms are bad enough that it warrants doing a procedure.
In case something does go wrong, can you recommend a good lawyer?
Funny. See him on TV all the time. The vaginal mesh, this, that, the implant, the hip implants. If you've had testosterone given to you, if you had this blood medicine for diabetes, come and call this lawyer, you're entitled to compensation. Your baby had a problem and you took this blood pressure medicine. It's not likely related at all, but it generates income for those who can. All right, very good, everyone. Thank you for coming, and hope it was
Thank you,
beneficial.
Thank you. Thank you.
You're welcome. Y para los pacientes quien habla español, se puede llamar por una cita y hablar conmigo directo para su problema y hacer la cita que es más cómodo para ustedes. Y como viví en México hace años, tengo la facilidad de ayudarlo. Entonces, se puede llamar y hacer una cita cuando quiera. Y si prefiere, puede pedir hablar conmigo directo. Y se puede tener el número celular del teléfono de las enfermeras mío. Gracias y ojalá que pueda ayudarlo. Nuestras oficinas están en Rreston, en el área de Fairfax, de Virginia, y tenemos direcciones y informes escritos en español para ustedes. Gracias.